Hello, and thank you for joining us for conversations and updates in gastric and gastroesophageal cancer. Practice-changing expert insights to improve outcomes. This activity is titled Practice-Changing Updates in Second-Line Treatment of Gastric and Gastroesophageal Junction Cancer. And during this segment, we will particularly discuss second-line treatments pertaining to HER2-positive disease. I'm Dr. Yelena Janjigian, Chief of GI Oncology Service at Memorial Sloan Kettering Cancer Center in New York. I'm joined by my colleagues, Dr. Shah and Dr. Klempner. Welcome. Okay, so we'll start with the concept of HER2 targeting in second-line setting. This was not something to be taken for granted. For many years, we've had negative studies in second-line setting, including for antibody-drug conjugate TDM1 and lapatinib and other HER2 inhibitors. So until Destiny Gastric 01 and then Destiny Gastric 02, we really have not been able to gain much traction in that space. And so Trastuzumab-deruxtecan is an antibody-drug conjugate studied in those settings. The Destiny Gastric 01 study was a phase 2 randomized study in third-line setting looking against Trastuzumab-deruxtecan against investigator choice chemotherapy, which is usually paclitaxel or irinotecan. And the unique portion about Trastuzumab-deruxtecan is that it has a high drug-to-antibody ratio, 1 to 8. It has a payload that is topotecan-like drug, so similar more to irinotecan, as opposed to TDM1, where it's a taxane-based payload. And in the initial positive study, it was done all ex-US, mostly in Korea and Japan. Maybe we'll start with, and so just to be clear, this drug is FDA approved now in second line. So after trastuzumab failure in the United States, while in some other countries such as Japan, it's still mostly approved in third line, where the study was done, the Destiny Gastric 01. So important parts about the FDA recommendation is to really consider biopsying the patient's sample tumor at the time of progression of disease on trastuzumab, as we all have known and demonstrated in several seminal biomarker studies that loss of HER2 and outgrowth of HER2 negative clone is an important mechanism of resistance to trastuzumab-based therapy in gastric cancer and occurs in up to 20% of patients. So perhaps we'll start with Dr. Klempner. Sam, what was your initial reaction to the FDA approval, based on a third-line study coming out of Japan? And would you call this an optimistic approval? Were you excited about it? What was your reaction?
Yeah, I mean, this is a real advance. This is a good drug, and I think it's just an advance in drug engineering and drug development. It's an active agent. When we saw the data in the New England Journal from 01, and as you said, it was done in the third line and later setting. I mean, it's really hard to ignore a response rate in the 40s and an overall survival, I think, was 12 months or better in some of it. You just can't ignore that data. And I think the FDA probably felt the same way. It's hard to not want to offer that to patients or have it as an available tool. So as you stated, the approval is for after trastuzumab. So in theory, it's freedom for us to give it second line, third line, whenever. I think we all like to think about the nuances of how to implement these new approvals. And we do definitely try to retest to try to guide that decision-making around second line or thinking about holding it for later line or whether or not we have a trial, of course. But I was quite impressed with the data. And it seemed to parallel data in other tumor types. And, the largely has been validated in a Western population now, as I'm sure you'll mention. But yeah, I was quite impressed and was happy to have it as a tool for our patients.
Yeah, so Destiny Gastric 01 was in third line in Asia. Destiny Gastric 02 was a single-arm, non-randomized study in United States and Europe, mostly, where the patients were mandated to get a biopsy before going on the study and treatment for central HER2 confirmation after trastuzumab progressions, which was not a mandate on Destiny Gastric 01. And so this was a single arm phase 2 study and almost identical overall response rate to what we saw in the larger randomized setting in third line. So it was a nice way to compare the results to the Western population, certainly to look at the toxicity profile of the drug, right? Because people forget that it's active chemotherapy. You have a high drug antibody ratio, so you do see bone marrow suppression, which is actually higher in later lines because the patients are more pretreated. And to be able to give it to patients in second line setting before the clinical deterioration and before they may be too frail to get these active agents is a nice option, in my opinion. Of course, you need to select those patients carefully, and often we do recommend a biopsy, either through liquid biopsy circulating tumor DNA or tumor biopsy endoscopically, ideally of the lesion that's progressing. Dr. Shah, do you recommend biopsies before progression or before deciding what second line therapy to offer in those patients?
Yeah, I mean, we try to do it. I think I am also equally encouraged by the activity of Trastuzumab-deruxtecan. I think one thing that we should highlight for people who haven't used the drug is that there is a rate of toxicity. It's not like trastuzumab. There is some systemic toxicity, but the thing that I think worries us a little bit is the pneumonitis. And actually, if you identify the pneumonitis early and you treat appropriately, you can manage it. But I think early on in the development of the drug, there were some treatment-related deaths from the pneumonitis that actually has gone away. So that's one thing I think it's important to highlight for everybody. But because of this toxicity, because you're not getting the activity for free, I think it is important to ensure that you still have the target. We talked earlier in another segment that HER2 overexpression or amplification is a subclonal state for gastric cancer, meaning that there are other mutations, other clones that might be active and dominating. So it's very, very plausible that in the first line setting with trastuzumab, you could actually knock out the clone that is HER2 overexpressing. And if you don't have that clone in the tumor biopsy or liquid biopsy in the second or later line setting, you may not be actually targeting anything with this drug, and you may just be giving toxicity. So I think it is an important aspect.
So let's have a mock case. It's a patient who came in and started first-line pembrolizumab trastuzumab chemotherapy for HER2 positive disease, had a great response. The primary tumor is eliminated. You scope the patient, and after a year or so on therapy, they're complete clinical response. So you peeled off some of the chemotherapies. Now they're on pembrolizumab trastuzumab maintenance. And let's say at month 22 or 24, which the median OS in phase 2 setting with pembro-trast chemo is 27 months. So let's say month 24, all of a sudden, there's a new liver lesion. It's about 2.5 centimeters. It's clearly a MET. And the patient is now asking you what to do next. Sam, what would you do in that setting?
I would rewatch this segment and I would listen to both of you guys. No, I think it's we would try to biopsy that liver lesion if it was accessible, and we would draw cell-free DNA at the same time for most of these patients. I think if the cell-free DNA is amplified and the lesion is negative, I would still consider that patient HER2 positive for the most part. If the biopsy and the ctDNA were negative, I think we would probably not move to trastuzumab-deruxtecan in the second line setting, although we would definitely have the discussion. If it was positive, more and more, I have been actually using this drug in the second line setting for people who are persistently HER2 positive. I do think that, in fairness, the Destiny Gastric 04, which is randomized head-to-head Trastuzumab-deruxtecan against Pac-Ram, is still a data set that I am interested to see when it ultimately comes together. Because again, to our earlier discussion, we haven't seen a head-to-head beating of Taxol and Ram, but I think broadly that's how we would approach the case. Biopsy, persistent HER2 positive, and no other contraindications to TDXD, we would definitely consider it.
So I want to make a point about 04 is actually not open in the United States because you can't randomize to non-HER2 containing arm, especially once you have an FDA approval, and it's actually struggling with accrual worldwide. So I think numerically and from the toxicity profile is the best comparison that we'll have, the numerical overall response rate and survival, and also the tox profile, which looking at Taxol Ram actually outside of the ILD risk, the TDXD typically performs better. But you can't get away with it that easy. So Manish, what if you biopsy the patient and the tumor is IHC 2+, and then FISH comes back negative, and let's say, it's a perfect world. You don't have to worry about the FDA approvals and you can really get anything for your patient. What do you think how would you think about it, the HER2 intermediate cohort?
Yeah, so that's a great question. So as I think we're all aware, this was a practice-changing study in breast cancer that was presented at ASCO of using Trastuzumab-deruxtecan in the HER2 low group, and there was significant activity. In another study with Trastuzumab-deruxtecan that included colon cancer, and if you had the HER2 low population, the activity was less than the HER2 high population in GI cancers. And I think for me, it highlights once again that breast cancer HER2 positive disease is not the same as a GI cancer HER2 positive disease. And I think for that reason, if you were IHC 2+ FISH negative, given that there is some toxicity with Trastuzumab-deruxtecan, I would be hesitant to use it. I think what I would do is save it for third line and rebiopsy, because I wouldn't be surprised if I found clones that were HER2 IHC 2+ FISH positive or 3+ later, but I might use Taxol Cyramza, and if the patient was actually for systemic cytotoxic therapy in a third line setting, I might consider it then, but I probably wouldn't use it in the second line setting.
Agreed. That's an excellent point and something we really should expand on for just a minute. Remember, Destiny Gastric 01 was a third line study, and there actually there was they looked at sub-cohort of patients that were biopsied first and then went on to have TDXD, and there was no difference in overall response rate. So this whole dogma, if we have to biopsy it, is important, but I think only if you consider this regimen in second line setting, particularly because of the risk-benefit ratio with ILD and so forth. And biomarker testing is always great and is important to get fresh sort of map before you go into the battle. But I do often then prioritize Taxol Ram in those HER2 low or intermediate or negative patients, and then come back to TDXD in third line. And still, because of this component of heterogeneity, we're just only as good at looking at something as a blind, essentially, biopsy result. And even liquid biopsies don't give us the whole picture. So we do, in a fit patient, could consider using TDXD in third line. This bystander effect is a very important question. Is it going to be enough to address HER2 low? I wouldn't, do it outside of a trial in second line, but it is a clinical trial question that we're trying to address. And again, Destiny Gastric 03 is amended now to include HER2 low intermediate cases. So you can, if it's open near you, you can accrue to that. I think that's really an important topic to continue to talk about. And there's a lot of, probably the most common question that I get from collaborators is about clinical trials that they're developing in this space. So a lot of discussion and excitement. I know both of you are focused on that as well. Thank you again for joining us for this segment in second line HER2 positive gastric and gastroesophageal cancer. Please be sure to click on the landing page for this activity to claim your AMA, ANCC, and ACPE credit, and to access supplementary slides and other topic segments in case scenarios. Thank you very much.